to empower patients with heart failure and their caregivers. Mixed method study. Over to you, doctor.
Thank you. I think I'm not able to share. Let me try again. Is everyone able to see my screen?
Yes.
Okay, good. So today, I will be sharing on our project led by Professor Chetna Malhotra from Duke NUS, entitled My Voice, which is basically the development and usability of a web-based advanced care planning decision aid for patients with heart failure and their caregivers. So what is the problem that we are trying to solve here? It's basically that, at least in Singapore, we find that advanced care planning rarely happens. And when it does, we almost, as physicians, never revisit the patient's goals throughout, the course of their disease. And we also find that while we have ACP in Singapore currently, there's low completion rates, and conversations are also often delayed or avoided. There is also uncertain trajectory in the course of a patient's heart failure journey, making prognostication difficult, and this in turn discourages advanced care planning conversations. Furthermore, when advanced care planning happens, it's usually a singular event, yet patients' care goals do change over time, and we need to accommodate that. There is therefore a gap in our existing tools, as can be seen by a scoping review of 11 web-based ACP decision aids found only 2 applicable to heart failure patients and only 1 tailored specifically for this group. There was no systematic mechanism to revisit care goals over time. Most tools don't actively involve caregivers in the ACP process, and none of them were designed specifically around heart failure's unique illness trajectory. Therefore, our study objective was this: to develop and assess the usability and acceptability of My Voice, a web-based ACP decision aid tailored for patients with heart failure and their caregivers. So how was My Voice initially built? It is definitely guided by the Combi behavior change model. There was an expert team and advisory board made up of multidisciplinary team, health service researchers, cardiologists, palliative care physicians, social workers, communication coaches, IT professionals, and some patient and healthcare provider representatives, who then came up with a content and prototype of what My Voice eventually shaped up to be, which are narration style videos featuring study clinicians translated into English, Mandarin, and Malay, which are the 3 most spoken languages within our country, with password protection and 2-factor authentication for patient privacy. And what is the Combi model? It's basically a model that's designed to build patients' capability, create opportunity, and increase motivation to have ACP conversations. So within My Voice, there's the patient and the caregiver module. The patient module consists of 5 steps of short educational videos of 1 to 2 minutes each. First step is to learn about heart failure. Second step is to think about what's important and clarify whatever questions they have. The third step is to choose a spokesperson, up to 2 surrogate decision makers. The 4th step would be to speak to their doctor to share the My Voice summary document. And the 5th step would be to revisit their My Voice document, and there would be phone reminders prompting periodic review. Completing the step 5 auto-generates a My Voice document that will be emailed or texted to the patient and their nominated spokespersons. The caregiver module consists of 3 steps designed to actively involve surrogate decision makers. The first step is to learn about heart failure, same as the patient module. Second step is to talk to their loved one, or i.e. the patient, and this provides guidance on opening and navigating advanced care planning conversations, which is tougher than you might think. And the third step is to support their loved ones. And how they do that is they are able to view the patient's completed My Voice document, of course, with the patient's explicit consent. And during the testing procedure for My Voice, we used a mixed methods design. across 4 public hospitals in Singapore. Basically, we conducted qualitative interviews, which comprise of open-ended feedback, iteratively revised, and based on that, we iteratively revised the website's content and design. And we also conducted quantitative surveys and estimated usability and acceptability using the Ottawa scale. And finally, we had conducted some tablet-based sessions whereby participants viewed the modules on a tablet, and staff ensured all steps were completed in one sitting. Who took part? We had 30 participants across 3 stakeholder groups with a 68% response rate. Languages used were English, Mandarin, and Malay, with English being the most well-represented language, which is, it extrapolates to the language that most people use in Singapore. Theme 1, navigating the website. So when we got feedback from these participants, what we heard was that all patients, caregivers, and healthcare professionals described the website as easy to use and with a simple layout. However, 2 healthcare professionals flagged the risk for older patients in view of smaller text, difficulty with scrolling, and limited eyesight. So some changes were made. We added an expected completion time and a progress bar, increased frequency of navigation buttons, increased font size and improved font color contrast, and added a drop-down list of common queries to the help section. In terms of content and duration, we heard that the language was clear and jargon-free, though some pages felt wordy. Quiz explanations about prognosis felt overly blunt and demoralizing. The quality versus length of life trade-off question was confusing despite many revisions. Therefore, we made some changes again, and we shortened the introductions, reduced wordiness throughout. We tried to make the quiz answers more empathetic while remaining truthful. We tried to split confusing answer options into clearer separate choices, remove the quality versus length of life trade-off question completely, and let the participants save their progress and resume across sessions. Finally, theme 3 was usefulness in understanding values and goals. And for this, most healthcare professionals did say that the website does help patients reflect before in-person ACP conversations, hence saving clinic time. Patients and caregivers also said it encouraged them to talk with each other about their healthcare goals. And finally, caregivers in particular valued that the document updates periodically as the patient's goals evolve. In terms of system usability scale scores, the cutoff for good usability is around 68 based on other studies published. And as you can see here, 70% of all participants scored above the 68 cutoff. And therefore, all 3 groups individually exceeded the threshold for good usability. In terms of acceptability, patients and caregivers did rate the acceptability either good or excellent. Highest rated items included understanding what's important for health, questions on life meaning, and talking with loved ones about end-of-life goals. Also, acceptability to the healthcare professionals, 70% agreed or strongly agreed with 11 of 15 items and felt that this My Voice document, is an acceptable way of exploring advanced care planning. And I also included here some of the feedback in their own words. From a patient, it was easy and straightforward, quite nice to use, very succinct. It tells me exactly what I need to do. And from a medical social worker, this will cut down a lot of professionals and caregivers' time. And next, just sharing what we think makes My Voice innovative. There are structured reminders built in to encourage periodic ACP review, and it's not supposed to be only a one-time event. It is disease-specific, and the educational videos and quizzes are tailored towards heart failure to provide context and urgency. It's also caregiver integrated, as there is a dedicated module that educates and equips the surrogate decision maker directly. And this document is multilingual. It's available in English, Mandarin, and Malay to support our diverse ethnic groups. And finally, one of my last slides is to note that This is actually a tool, but not a replacement for the advanced care planning document that we have in Singapore. So while healthcare professionals rated usability very highly, only 30% agreed that my voice is better than how they usually conduct ACP, and only 50% agreed it required no major change to their usual workflow. So what we interpreted this as was that my voice can be a patient preparation tool that's meant to complement but not replace patient healthcare professional ACP conversations. So these lower ratings are unsurprising. Some strengths and limitations of our study. Strengths include mixed methods design with iterative agile revisions, multiple ethnic groups, languages, and hospital sites involved, and one of the first web-based ACP tools for heart failure within Asia. Limitations include a very low response rate of 46%, partly due to older age and reluctance towards web tools. Sample is too small to examine variation by gender, age, or other demographics. Some patients were surprised to learn heart failure is incurable, and this actually signals gaps in prior healthcare professional conversations. Therefore, our conclusion is that my voice is a usable and acceptable tool that helps patients with heart failure initiate and revisit advanced care planning conversations with caregivers and healthcare professionals. And what's next for us is to study the efficacy of my voice in improving patient and health